We'd like to welcome JoAnn Volk, who's going to talk about all the things that we know are issues with respect to the private market challenges and with respect to the current status, what's going on, what are the changes. And with that, I'm turning it over to JoAnn.
Thank you, Marla. It's nice to see you. Hello, everyone. My name is JoAnn Volk. I'm a research professor at Georgetown University Center on Health Insurance Reforms. We're part of the Public Policy School at Georgetown. I've been at this conference in years past. It's been a little while. I think the last time was in Baltimore. So it's nice to join you virtually. Some of what I'm going to cover today, I know many of you already know, but I feel like it's a helpful refresher because I'm going to get a bunch of questions I know also about why does this thing happen and why is this allowed. So I'm going to just remind everyone what the ACA actually did to the Affordable Care Act, the rules that apply to individual market coverage, the employer coverage that I know many of you have, what's at stake with the Supreme Court decision to come, and a little bit about what you need to know right now. Okay, so the Affordable Care Act sought to improve access, adequacy, and affordability, particularly in the individual market. This is a place where prior to the Affordable Care Act, people with pre-existing conditions could not get coverage. They were denied outright. They were invited to enroll in a plan. After medical underwriting, they would typically find that entire categories of benefits were excluded. Typically, that would be prescription drugs, maternity coverage, mental health and substance use disorder were routinely omitted from benefits. And then for any given individual based on their health conditions, there may be a waiting period where coverage is not available for the conditions you have under that plan. So the individual market rules from the Affordable Care Act guarantee that everyone will get a policy or an insurance policy regardless of their health status, and it has to be renewed if you choose to remain in that plan. There can be no coverage exclusions for pre-existing conditions. Premiums cannot vary based on health status, gender, or a bunch of other factors that were routinely used, like where you worked, what kind of industry you worked in. It can only vary based on age and family size and, the rating area where you live. There are minimum benefit standards known as essential health benefits, 10 categories of benefits that must be covered so long as they meet a state-defined benchmark plan. Dependent coverage up to age 26. Even if you have your own employer offer, you can stay on your parents' plan. A cap on out-of-pocket costs. It's a big number, but it is still a cap, about $8,500 a year for an individual plan, $17,000 for a family plan. Preventive services available without cost sharing, no deductible, no copays if it's recommended by experts that you get it. And then no annual or lifetime dollar limits on benefits. And I know this is big for people with hemophilia who would routinely cap out of plans. They'd lose their eligibility based on these dollar limits. There are also rules that apply to employer plans. If it's a small employer buying an insurance policy, it's basically the same rules as the ones I just listed for the individual market. And that's because the small employer market before the ACA was about as difficult as for individuals. If you were a barber shop and your workforce was older, or someone had a bout of cancer, it would be impossible for that employer to get coverage, affordable coverage for their employees. So the reforms for small employers mirror those of the individual market. For large employers, though, and it is generally 50 or more employees, and for all employers that self-insure, some of whom may be small employers, there were far fewer federal rules. The assumption was that for most people, the large employer market was working relatively well. The average actuarial value, how generous the plan is close to what we would call a gold plan now in the marketplace, about 80%. And they routinely are typically covered a broad range of benefits. The reforms for the large employer market were fewer than those that applied to the individual or small group market. There is dependent coverage up to age 26, the preventive services without cost sharing, the prohibition on annual or lifetime dollar limits. Again, I know important for people with hemophilia who had employer plans that they lost eligibility for, and then the cap on out-of-pocket costs on any benefits that would be considered essential health benefits. And this is where it gets tricky, and I think probably brings up some of the concerns I'll hear about later in the question and answer. Large employers do not have to actually cover essential health benefits, but they have to have a cap on out-of-pocket costs on anything that would be considered essential health benefits. So there's no obligation that they recover the 10 categories of benefits. If they do, they must, include this cap, and they can't have the dollar limits on those benefits. Before the ACA, there really were few, just to further drive home this point, very few benefit mandates for the large employer plans. There were things like the Newborn Act, which requires, a minimum stay after delivering a baby, and the Women's Healthcare Reform Act, which had a set of coverage mandates for services related to mastectomies. But other than that, there were, the other things were like HIPAA, non-discrimination, genetic information, non-discrimination. Even the Mental Health Parity Act didn't require anyone actually cover those services, just that if they were covered, they had to be on par with medical. So this has always been a more lightly regulated area of coverage. Then there's a set of plans you may have stumbled across that are beyond the reach of the ACA. The law specifically carved out grandfathered plans, which this was that famous, if you like what you have, you can keep it. So plans that were in existence when the law was enacted and signed, and if they only made minor changes to benefits and costs, those plans are exempt from many of the reforms. They do have to provide dependent coverage up to age 26, but among the ACA protections you're probably familiar with that do not apply is the cap on out-of-pocket costs, the preventive services without cost sharing, coverage for clinical trials and costs associated with that, and then the external review, an independent party looking at your appeal to your insurer for denied claims. Then there's also a whole bunch of plans out there now sold to individuals, in some cases small employers, that are also exempt from the Affordable Care Act, probably most notably short-term plans, which now with the revised rules can last for up to 12 months, like 364 days, and be renewed 3 times over for about 3 years worth of coverage under a plan that can discriminate based on health status. And then healthcare sharing ministries have grown in recent years. It's not insurance at all. It's just the opportunity to submit bills and hope that you can share, so that others will share in defraying those costs. And those are definitely being more aggressively marketed, I think, since the loss of the mandate penalty. As long as we're not steering people to coverage that they have to avoid the penalty, I think it's been sort of a boon to unscrupulous marketers who want to get these products out there with their lower monthly cost. And though Marla lobbied hard for me to include a table in this, a version of her favorite table, I think, I did not take a stab at that, but here I provide here a link to a resource we have. It's an online navigator guide. I think I've probably shared this in the past with a bunch of FAQs about the Affordable Care Act rules for individual and small employer and large employer plans, but there's also this specific link, a table that shows you the various provisions and whether or not they apply to individual, small group, large group, self-insured, grandfathered, and then these short-term plans and healthcare sharing ministries. Now, I know you've already heard about sort of the legal basis for the current challenge to the Affordable Care Act, in which there'll be oral arguments on November 10th, and the decision could come as early as next spring or early summer when they close out with their decisions in June. So I'm not going to get into the basis, the arguments being made. I wanted to share today some of the possible bad outcomes of that and the implications for people who rely on these protections. In one version of how this might get decided, the entire law is struck down. That's certainly the position that the administration is taking, that because the mandate now comes with a zero penalty, the whole law must fall. This is not the position they started with, but it's where they are now going into oral arguments. That would mean the loss of protections for individuals and those in employer coverage, but also more broadly, everything else. There's Medicare reforms in there. There's Medicaid, of course, Medicaid expansion and other reforms that would all be swept away. And estimates are that more than 20 million people would lose coverage pretty much immediately. Another version of this is that they just strike down the pre-existing conditions protections, that famous, I think was part of one of the earlier cases, three-legged stool, that the mandate and the subsidies and the pre-existing condition protections are all interwoven and one cannot exist without the other two. And in that scenario, they would eliminate the guaranteed issue that I mentioned. Everyone must get a policy, the fair rating rules that you can't be charged more based on health status, and the pre-existing condition exclusions. If those were to go away, there are about 10 states right now that have enacted their own state level protections, those three, plus the essential health benefits, which is also key for people with pre-existing conditions. And in that case, those states would be basically just fine. They'd carry on with the status quo, that those protections in state law with everything else in the ACA, the subsidies and so forth, would mean that they could carry on as if nothing happened to the ACA. But there are 25 states that have nothing on the books that resembles those ACA protections, and the rest of the states are somewhere in between. They might have one or more of the protections, but not all of them. So it would be a patchwork of protections. And then finally, if the pre-existing condition protections go down, but also the subsidies, the premium tax credit and cost sharing reductions that are available to people with incomes under 400% of poverty, that would mean that even in states that have adopted their own ACA-like pre-existing condition protections cannot sustain them. And I want to just share, we know this because, prior to the ACA, a number of states have tried their own reforms. In fact, on the eve of federal health reform, 5 states prohibited insurers from denying coverage or charging a higher premium based on health status. Massachusetts was among them, and the only one that had their own version of subsidies. But in the other states, they basically could not be sustained. In New York, for example, rates skyrocketed to as much as $1,300 a month in 2012. Kentucky's market went from 23 insurers to just 2, and Washington State, in response to their individual market reforms, lost all 19 of their insurers who had previously offered insurance in the individual market. So you can't guarantee everyone can get a policy and doesn't have to pay more based on health status and expect that to last without, ultimately having a very small sick risk pool that is unsustainable. It's the subsidies make that doable. The other path, if the ACA is upheld and we get to go back to just enjoying the full breadth of the law, with a willing Congress, people certainly have identified multiple ways that the law should be fixed or strengthened or improved. I think probably pretty high on everyone's list is improving the subsidies and making it more affordable. In fact, for people over 200% of poverty, the tax credits just do not help that much, and there's not much in the way. There's very little or no help on the out-of-pocket costs. Those deductibles can be huge. And then another area that people are interested in, and I'm sure you all will have some questions or maybe want to make comments on this, is making it easier to access to qualify for premium tax credits, even if you have an offer of employer coverage. As you likely well know, if you have an offer of employer coverage and you want to go to the marketplace to buy a plan, they're going to ask you if your coverage meets minimum value, which is 60% actuarial value, and if it's affordable, looking at the cost to buy that plan relative to your household income. And it's very hard to show that an employer plan fails on either of those tests. And so even people who have pretty lousy employer coverage cannot turn that down and go into the marketplace with premium tax credits. There is substantial interest in looking at that so-called firewall again, the test that you have to clear in order to get premium tax credits, and seeing if there's a way to ensure that employer coverage is better, that you don't have to get locked into this lousy plan and barred from getting premium tax credits. And of course, then there's the so-called family glitch, which means that there are many cases where the dependents, the spouse and children of an employee, their plan is not at all subsidized for them to buy into their family member's employer plan. It's not actually affordable, but by the technical definition of the ACA, it is. And so they're stuck with that lousy employer plan, can't get into the marketplace. People are interested in some fixes for that problem to allow those families to get subsidies. And then the other area where we might see improvement is there are states now who have been already taking some steps to strengthen their marketplace and improve affordability. I've shared a link here to a map that colleagues keep up to date with state action, looking at a number of different things states can do. Just to name a few here, 4 states have enacted their own individual mandate: California, New Jersey, and of course from the prior to the ACA, Massachusetts all have individual mandates in effect. DC too, and Vermont, but without a penalty. A number of states have enacted their own subsidies, whether it is to make it richer subsidies for those under 400% of poverty or to extend it to people above that cutoff. California, Vermont, and Massachusetts currently have subsidies in place. New Jersey will have them beginning in 2021, Colorado in 2022. But there are other options for states to improve or strengthen their marketplace. So what is a consumer to do while we wait for the fate of to hear about the fate of the ACA and everything else going on? I would say carry on and enroll. It is typically the time of year when you get to re-enroll in your employer plan. So all the ACA protections still apply to those employer plans. The marketplaces will be open for business soon. There are state-based marketplaces. There's more every year. Pennsylvania and New Jersey just came online this year. Virginia's on the way to becoming a state-based marketplace. Maine also to come. I've shared a link to a map that shows you who's got a state-based marketplace and who relies on the feds to enroll people through healthcare.gov. But state-based marketplaces have greater autonomy and flexibility. Interestingly, a lot of them have made the case to their legislatures that it's fiscally more prudent to run their own marketplace because they pay a user fee to the feds. And under this administration, what you get for the user fee is diminished each year. There's been a 90% cut to funding for outreach and enrollment. Navigators have been cut by 80%, those unbiased consumer assistance, enrollment assisters. So the user fee has not been reduced that much, but what you get out of it is substantially reduced. So states like Pennsylvania have made the case that they can run it a lot more efficiently and get more out of it. So you may see more states moving over to state-based marketplace. And they really do have greater autonomy to set their own rules. All but one state-based marketplace, for example, have now in place a COVID-19 special enrollment period to let people enroll outside of open enrollment, even if they don't qualify for another SEP. So there are millions of people losing their jobs and with it, health insurance, and that is a official special enrollment period to get coverage. But in the interest of everyone having access to insurance in the middle of a pandemic, most of the SBMs have just opened the door with long-running SEP to say, come on in and get coverage if there's no other reason than we're in the middle of a pandemic. Many states who have federal marketplaces and rely on the feds to run their marketplace have called on the administration to do the same for the federal marketplace, to open up a special enrollment period, but so far they've refused to do so. And of course, Medicaid is open year-round. In non-extension states, it's going to be hard to qualify, but in all cases, go to the marketplace and see what you would be eligible for. But when enrolling, keep in mind that the only place you can be guaranteed that the plans meet the ACA rules is in a marketplace. And certainly if you qualify for financial help, you should get it. It may be a little intimidating to try to think about projecting your income in the year ahead if your family's experienced some job loss, but the system is set up, it may be a little clunky, but it's set up to make it possible to adjust your assistance that you're getting if your circumstances change over the course of the year. You get a job, you lose a job, whatever it may be. But if you don't qualify for financial help, you may be better off buying outside the marketplace, in large part because the premiums in the marketplace are inflated to reflect the fact that you have to provide cost sharing assistance to people under 250% of poverty, but the federal funding for that no longer exists. So the marketplace has responded by allowing their insurers to load up the cost of that on their silver plan. So the premiums are actually inflated in the marketplace. You could get the same plan for less money off marketplace. But when you go off marketplace, there's a lot more going on out there besides just ACA plans. There's a lot of deceptive marketing. States have found a lot of unscrupulous broker agencies that are signing up people. I mean, there was just GAO did a report where they had these recorded phone calls with salespeople assuring people that the salespeople were assuring people, the callers, prospective buyers, that it would cover pre-existing conditions and it included all the benefits they needed, and it didn't. So that's happening a lot more. We know from some research we've done at Georgetown that online shoppers are often diverted down to a path to non-ACA plans. You may Google and say you want an Obamacare plan or an ACA plan, and the algorithm will take you down to something other than an ACA plan, like a short-term plan. One shortcut to sort of figure out if what you're buying has to comply with all the non-discrimination rules of the Affordable Care Act is to ask for the summary of benefits and coverage, which is a ACA required document, a standard format, which on the last page must tell you whether or not it's minimum essential coverage. So if they can't produce that document, that's supposed to be available to people upon request. if they can't produce that document, that's a sign that you're not dealing with an ACA plan. And just a word of warning to be extra careful, because if it turns out that the plan is not what you thought you were buying, you may have to wait to get into other coverage. Buying a short-term plan and finding out it doesn't cover what you need is not the basis for a special enrollment period into the marketplace outside of the annual sign-up period. And that is my review of the ACA and what's ahead. I know you all have a bunch of questions, so I'm ready to hear them.
So let's start from the top. Any further insight into what is considered essential health benefits? And I'm not sure, beyond the categories, like what within the categories, what would be considered essential?
Well, so the law only had those 10 categories in there, and then said it was, well, in regulation, the feds decided to leave it up to each state to select a plan among 10 options to say, this is a plan that we're going to call our benchmark plan. In some cases, it didn't cover all the 10 categories. They had to supplement and say, here, okay, this plan plus these categories is what you have to match if you're going to sell a plan to small employers or the individual market. But it's otherwise not defined what it means to have prescription drugs, for example, or hospital care or maternity care. There's no minimum standard for what that is. It all relies on what the state has determined to be their benchmark plan.
Which is in part, I believe, why you see a lot of the state to state variability within, what they cover and how they cover it, correct?
So for the prescription drug benefit, there is some definition from the feds, which is that you have to cover at least one drug in each category or class of the U.S. pharmacopoeia. They had to sort of set some floor, and the floor is pretty low. For some populations, it's not even reflective of what's needed, but those are the minimum rules.
Someone writes that they've seen plans that don't have to cover up to age 26 unless a dependent is a full-time student. So they're wondering if those are considered grandfather plans.
I don't know, but that should apply even to the grandfather plans. There was a moment in, I think, the early years, 2012 or something like that, you didn't have to cover a dependent who had their own offer of ESI. But it is now the case that you cannot condition it on living by themselves, having a job, or being a student, none of that. It's just based on age now. So if that's the case, that should not be allowed.
Yeah, that should absolutely not be allowed. With a plan purchased via a marketplace or through the ACA, is there a grace period in which they can try the plan, then cancel and choose another plan if it doesn't meet the patient needs?
That's a good question. It's been a while since I've had to think about that one. Not a lot. I mean, I would have to double check on that one. It's not what they call effectuated until you pay your first month's premium. But then you can't drop it and say, I didn't like this plan. I mean, there was a period where I think before it took effect. So I guess that's the thing. It's if you sign up in November for a plan that takes effect in January, as long as it's still open enrollment period, you could change plans. But once it takes effect, you've paid your premium and it's January 1, there's no way to change at that point.
Interesting. If the employer excludes specialty drugs, can one purchase at marketplace and qualify for tax credits?
Your version of what is an employer plan that doesn't measure up and should be reason for you to get tax credits is not the official ACA definition. It is strictly saying has to meet 60% actuarial value and then this affordability test of the premium. It's not about what is actually in the plan. It doesn't prescribe that you have to cover specialty drugs as part of that analysis.
It's difficult to have contacting insurances to find in-network specialty pharmacy provider and being able to navigate the services that a patient would need, right? Because it's difficult to find factor, right? Which I think is more about what you were mentioning on the U.S. archaic, I say archaic because it basically is, right? The archaic system in which they categorize the drugs in the one drug per category or class.
But also the Medicare difference, right? That stuff is Part B. I mean, is it also related to the fact that under Medicare would be in Part B and not a Part D, considered a hospital benefit, or facility benefit, not a drug, right?
Right, correct. Because factor is a Part B covered, and all the drug categories are classed at the U.S. Farm, however you say that, USP categorizes it, are Part D, historically, Part D covered drugs. So I think it's still an issue that we work very hard to try to reconcile and correct, and it's always a problem, basically, right? Because we can go back and forth about why that is. So someone's asking you to repeat what you said about the inflated premium in the ACA regarding if one does not qualify for financial help.
So you may remember a couple of years ago, the administration said that they were not going to continue funding for what's called the cost sharing reductions. This is the name given to if you qualify for help on filling in the deductibles and lowering the copays for people under 250% of poverty. And so the way that worked was the feds would pay insurers to just make available to you a plan that just was more generous on those deductible and copays than it would be for someone else. You didn't have to pay out more money and get reimbursed. It was just a more generous plan that you bought. On the back end, the feds paid the plans, the administration cut off those payments. The insurers still had an obligation to continue to offer that more generous plan, whether they got paid or not. And so they dealt with that, having to provide that benefit without reimbursement from the feds by building it into their premiums. So you see higher premiums on the marketplace to account for the fact that they're providing subsidies to some people for which they're not reimbursed. That's called silver loading. Every state sort of dealt with it that way. And so you will see the same plan costs more on the marketplace because of that. And it ended up having the effect of increasing the value of the premium tax credit, because that's based on the silver plan in the second lowest cost silver plan in the marketplace. So when the insurers built that extra cost into their premiums, it also inflated the premium tax credit, which actually had the benefit of making it possible for some people to buy up to gold and others to get a zero premium bronze. It has all these other benefits. But for the person who doesn't qualify for financial assistance, all of that is useless because you don't want to pay more out of pocket. You go off marketplace and then you're in the pool with everything else. That's why you have to be super cautious.
And is there a way to validate the off marketplace plans? Meaning, I had heard that at one point you could go to the Department of Insurance in your state to figure out if the off marketplace plan was equivalent or similar to an on marketplace plan. And I'm not sure if they've been keeping that up.
Yes, that is absolutely a way to check as well, is to go to your Department of Insurance. You'd have to have the full name of the plan. I'm not entirely sure how easy it is to figure it out, but yes, all the plans that are sold in the state, if they're legit, whether they have to comply with the ACA or not, have to register or get licensed from the Department of Insurance. So the Department of Insurance should be able to tell you if what you're looking at is ACA compliant. I mean, all that said, none of that's going to catch the fraudsters, right? So I guess there's a benefit. Some insurance departments figure out that there's fraudsters out there because consumers call and say, what is this thing I'm looking at?
When an employer approaches an employee and tells them, you're costing our plan a great deal of money and we want to offer you X as opposed to staying on our plan, is that kosher?
Yeah, I mean, it's a delicate little dance, but it's not. If they're not forcing you off because of your health status, they're just giving you a really good reason to leave or making you feel lousy if you stay. That's within the realm of permitted.
Good to see you, JoAnn.
I hear you.
One thing I will say is we are already seeing, I'm trying to remember who it was that asked the question about employer plans that are dropping specialty coverage. We have heard from 2 or 3 that are looking at dropping specialty coverage across the board. Now, in some of those cases, they think they have an option that they're offering to their employee. And so this is something you guys should be watching for too. So for example, one of the plans said, but we've gotten this service, and they give them a card, and I can't remember the name of one of the groups, but I've seen a few of these that says, this group will be able to help you purchase drugs at a reduced cost or get them free. Now, what that actually ends up being is one of those prescription discount cards.
Yep.
And quite frankly, none of those cover any specialty drugs. And they were sold this as this will help you for those employees who are losing their drug coverage under specialty drugs. And so it, quite frankly, didn't cover a single specialty drug that we saw. It's one of those, again, consumers beware type thing, because the person, said, well, but they said I could get free drug. And I'm like, well, think about it. If this was optional, everybody would choose something like this, and these companies would be, it would be a going out of business sale, right? So anyway, there's that. Then there is the issue, and I was talking to, I think it was Marla yesterday, maybe, about this, all of these skinny plans. It's not real obvious that they're a skinny plan. I had to really look through one of these plans for somebody that came to me looking for some help. And I know what to look for. At least I feel like I know what to look for, and it took me a lot of time researching it. And then finally actually going to the health plan, to somebody I knew, for them to say, oh yeah, you don't want that plan. It's not going to pay for anything.
What did you see when you figured it out?
What I saw was there was, when it talks about your co-pays and all that kind of stuff, you get down to the bottom and you see that you have a huge out of pocket. And I don't think it was very clear in how that went. I mean, it was literally like you had to, in effect, there were very few things that you could get done in this plan without paying a deductible. It was almost like a high deductible health plan it had like almost, I think one of them had a $15,000 out of pocket, one had a 20. And it's these, again, it's skinny plans. You pay this much and then we'll start paying 20%. Not we'll start paying 80%, but once you've paid this part of it, then we'll start paying 20%. Then it was going up from there. It was just what was the key indicator to me was the cost, right? The person came to me and said, I know this is expensive, but I found this plan I can get for $170 a month. And I instantly said, you're not getting a plan for $170 a month. But again, so I think that that's very difficult. I think when they drop all specialty drug coverage, I don't know if you'll remember this, JoAnn, but we did challenge this with one health plan a few years ago. And we were able to get them they definitely were able to get in on the marketplace, but we were actually able to get them subsidies too, because when they looked at it with the other coverage that the plan had, it did fall below that actuarial value.
Oh, it failed to meet minimum value. I didn't remember that. Okay.
Right.
So specialty drug, the question is specialty drug an essential health benefit?
It depends on if the state benchmark plan has specialty drugs. But there's also, just to make everything even more complicated, so the large employers don't have to cover EHB. They just can't apply dollar limits to what would be considered EHB if they offer it, but they don't have to offer all 10 categories. And then when they want to say like, yeah, but this is the benchmark we're using, they can look at any of the 50 states to say, I'm basing this on the Alabama benchmark or whatever. So it's really there's broad flexibility. Which means that no, there's no requirement that they cover specialty drugs.
And I would say to you also, I see these questions about, can a minor qualify for an SCHIP plan if the patient's a minor and the employer's not covering specialty drugs? And I see that somebody else said, well, they may qualify for Medicaid as a secondary. I'm going to tell you that varies greatly from state to state, because I will tell you that most states, if the patient is a minor, they look at their parents' income level in determining financial eligibility. Even if your employer's not doing, is not covering something, just because the individual has a chronic disease is not going to help them get into Medicaid, because they are going to look at your income levels. And JoAnn, tell me if I'm wrong on CHIP, maybe there's a way to do that with CHIP, but with traditional Medicaid, no.
No, the only thing with CHIP is that some states, the eligibility level is higher than the Medicaid 138. So it's still the family income, but it's, more generous income.
But it's still fairly low. That's the problem.
Yeah, I will just say on this ESI thing, it is an area that people are trying to figure out if there's some more to do here. There is the statute, and the statute says you have to consider, if you want to make changes, if it requires a change in law, which is a lot harder, or if there's room within the current law to just write the regulations differently. And that's easier to do, but it's got its limits, of course. So the law says 60%, and the affordability test is pretty high too. It's like the premium for self-only coverage is more than, I don't know, it's about like 9.8% of household income. So it's hard to clear that. But people are looking at whether or not you could do a little bit more with that AV to say that it's got to do, I mean, I don't think it's you can get to the granular level of saying it has to cover specialty drugs. But, they did modify the definition of actuarial of minimum value before, because they found out there were a couple of high profile articles that found these people had plans that qualified as minimum value, covered, cleared that AV calculator, came out the other end and said, yep, your benefits cover on average 60% of someone's costs. And they still managed to not cover hospital or physician care, one or both. And so the federal regulators said, oh my goodness, we had no idea that could happen. So now we're going to modify the definition, 60%, plus you have to cover hospital and physician, right? Which are 2 of the 10 categories. But it would be a leap from there to say like, yeah, but you have to cover all 10. But if, it was a lousy prescription drug benefit, or they eliminate entire categories, you might be able to make the case that, and it should be 60% AV plus hospital and physician and drugs. But it's a slog to try to get there, to just get changes via regs instead of a change in the law.
And I think that that's a super important distinction that you might want to reiterate again, like, what is considered minimal essential coverage, right? And income, and how do you, because quite often, and I think Michelle has also gotten many of these calls, right? How do you prove that what you currently have is not considered essential coverage, right? If it doesn't cover the drugs you need, then to the patient, right, it's not matching my needs, right? Similarly, but if they don't meet the technical definition, when I really mean like technical, like based on income and an actuarial value, you can't really qualify for minimum. You can't qualify that it's not considered minimal essential coverage, correct?
Yeah, but actually 2 different things. Minimum essential coverage is different from minimum value. So for purposes, like when you're looking at whether or not you can leave your employer plan and get premium tax credits, that's minimum value, and it's all about the actuarial value, right? The on average share of costs that would be covered under the plan. 60% is, not a lot. 90% is a much more generous plan, and you'd pay less out of pocket. Minimum essential coverage refers to like a plan that, in the world where we had the individual mandate, if you had that, you met the requirement to have coverage. And most employer plans, all employer plans met that. So if you had it, you could avoid the penalty. When I said earlier to ask for the summary benefits and coverage and ask if it's minimum essential coverage, the form actually says on the last page both things. Does it meet minimum value? Is it minimum essential coverage? The point about the MEC is that, like, if it's lousy individual coverage, like a short-term plan or fixed indemnity or cancer only, that would not come with an SBC. The requirement to offer that does not exist. And even if they did it voluntarily, they couldn't claim at the end that it was minimum essential coverage. That's like your shortcut way to figure out if it's ACA compliant.
And we have some of these definitions are outlined in our insurance toolkit, which we still have on our website as well, and it was updated. So I think that's there. I think there's some other good comments going on in the chat. And Sabrina, thanks for reminding me. One other option would be to look at children with special health care needs in your state, if your state has that, and see if it would allow for, a lot of times what they'll do is they'll purchase a plan for you, or they'll help, purchase. In our state, it was they would they would pay the premium for the high risk pool, which no longer exists, right? Or they would help pay for the actual cost of some of the drugs. And what happened was, in connection with hemophilia, it was cheaper to pay for a premium than it was to pay for the drug. So that's why they chose to do that. That being said, at least in our state, there is a financial eligibility requirement for that program as well. So again, those are all the things you need to look at. And I believe it was Cynthia talked about another option that we've done recently with somebody too, where we were able to get that patient on the assistance program through the manufacturer for a certain time period, and then that the parent found a different job with a different health insurance plan. Or in another instance we had where they were not fully utilizing both health plans. The husband and wife both had insurance, so we were able to get the child transitioned over to the other insurance plan. So I think there's a lot of those. I think the concern right now is that, look, what happened before was insurance reform. It wasn't necessarily really health reform. It didn't change costs in hospitals, those kinds of things. That was going to be the next step we had to go to really impact what is the overall cost of care. And now, if we're going to change this structure we have now, we're going back to doing more insurance reform and still not addressing the cost of healthcare, which I think is a big problem. So, but I think this next year, there's a lot that we're going to be looking at.
Yeah. All these things, these limits, this how much you get if you qualify for subsidies, who qualifies for subsidies, how hard it is to say, to meet that test, to say, kiss that employer plan goodbye, you get to come over here to the marketplace with tax credits. All those rules were set to meet, the whole bill had to come under $1 trillion. It was like a political decision, maybe more than you need to know, but no one said this is legitimately affordable to pay 9.6% of your income for premiums and then still have a high deductible. And no one said that you should get stuck with lousy coverage. You should be able to get premium tax credits if it's better for you. But they, if you lower that wall, what they call the firewall, and allow more people to jump over it and leave ESI employer coverage and get to the tax credit, that's a greater federal cost. And it's all better for people on the other side. But I guess my word of warning is all this stuff costs money, to make those subsidies more affordable and to make it easier for people to leave lousy coverage employer plans and get tax credits. The intent was to make sure that we didn't just completely eliminate the firewall and let everyone choose. Although, the Biden plan is very broadly defined at this point, but I know that among the things are that they want to take a look at that firewall. So it's an opportunity to say, this may technically meet minimum value, but this plan is of no use to me because we have a child with hemophilia and it doesn't cover factor. I might as well not have coverage. So
and they're also
that's a discussion to have, and but just a word of warning that it's not that people think, it'll come with a price tag.
part of that plan is to increase the subsidies substantially, right? To cover well beyond 400% of the federal poverty level, which apparently, it would be similar to a Medicaid buy-in in which you have a sliding scale that is proportional to your income so that everyone is paying into the same amount of income, basically, right? Based on income, is at least my understanding of that increased subsidies and federal poverty level. There was another question about, can you further define or explain what a skinny plan is?
Well, it probably encompasses a lot of things, but one of the versions of this is that, again, the only requirement that applies to an employer plan is that you have to cover preventive services without cost sharing, and you can't apply dollar limits to what would be considered EHB. But within that, and we just had this whole conversation that nothing else is actually required, So there were plans that were getting away with just covering preventive services and not a lot else beyond that. But what was covered was without dollar limits, and it met the definition to be, the rules for group for employer plans, and so was minimum essential coverage, which made it harder for you to get tax credits. So that's what a skinny plan was. And I think there was an analysis done early on that I think the Department of Labor did a survey of employer plans and said, as we're working on this actuarial value calculator, let's see how many plans are out there that are close to this 60%. And they said, oh, don't worry, it's 2%. Everyone's much higher. They're 80%, 85%. And lo and behold, some employers got creative and said oh, we can really shave back here and still meet all the rules. So that, in the original version that I understand, is what a skinny plan was. I'm covering preventive services, cost-free, and whatever else is covered, not much, doesn't have dollar limits. So I'm good with the law.
The way I look at a skinny plan is think of it as a catastrophic plan, right? It's only going to benefit you if you have something really major happen. And even then, you're going to come out of pocket a big part of that cost, but you at least have some coverage once you pay that amount. I mean, that's kind of the way I looked at it was, the person that I was working with was somebody who had no health issues other than mental health issues. And I said, you know what? It's cheaper for you to pay out of pocket to go get your mental health services than it is for you to get one of these plans, because, in order for him to have reached anywhere where it would have started to pay, he would have had to have been hospitalized for long periods of time. He would have had to have been, he never would have gotten to the point where they were paying. He would have been paying out of pocket every single month plus his premium.
So I would say, I mean, there are a ton of marketplaces where you're right. The bronze plans, they have huge deductibles. Unless you got hit by a Mack truck, you wouldn't likely get benefits. But they come with, in some cases, zero premium. So at least you'd be protected if you got hit by the Mack truck. You may pay out of pocket for the few things you need. I think catastrophic even come with like 3 primary care visits a year. But otherwise, it's a huge deductible that is basically the equivalent of the out-of-pocket limit. But I would say shop, because there are some plans that are free or close to free.
And I think that that's more so what we're telling people, is that they may not necessarily realize what, in fact, they qualify for if they haven't looked in a while. And especially if they've considered a life change, right? If they were recently laid off, furloughed, or had reduced hours. But I think another thing about the skinny plans that I wanted to bring up, because it's how a patient learned that they actually had a skinny plan, was because they were paying into what seemed like a Costco-like drug cart, basically. They said they had to buy, first of all, a separate pharmacy, right? And it ended up being they were paying $50 for access to Costco for drugs, right? And none of these would cover Factor, of course. And it turns out it was a ministry plan. Kaiser did an analysis which showed like 85% didn't have any pharmacy coverage whatsoever.
Pre-ACA.
Pre-ACA, yeah.
Yeah, I think none offered maternity without buying it separately. Yes, and like more than half excluded mental health and substance use disorder. But yes, and then the other big one is prescription drugs.
I'd like to end on one, Marla. I do want to try to do this real quick. Lynn asked the question if the Department of Labor or ERISA would consider the absence of specialty drug coverage from a self-funded plan a form of employer discrimination. And I think the answer is no, because I went through this before. And the reason is it would be different if they said, I am going to eliminate coverage for hemophilia A patients. They couldn't do that. But if they went across the board, and I think it's also important to note that pharmacy coverage is actually is actually not mandatory even in Medicaid. Am I correct, JoAnn? So it's not mandatory. Most of them do cover it, but it is not considered under their requirement from CMS. They don't have to cover pharmacy prescriptions because I was absolutely shocked by that. But what I'm saying is I think if they do it broadly, they can do that. It's just if they defined it down to a specific group of people within a group, I think is where it gets considered discriminatory. Right.
Yeah. I mean, it is permitted to exclude, treatments. Yes, there's no requirement that if you had someone who submitted a claim and suddenly mid-year, the plan changed to eliminate that benefit, that you would have a big case for discrimination. But if upon plan renewal, they just decide that they no longer want to cover Factor or, epilepsy drug or whatever, that is permitted.
Okay. And with that, I would like to thank you guys. Thank you. Michelle's still here, right? Where'd you go? Oh, there she is.
I'm here.
It was a great reunion, albeit virtual, and we want to thank you again. Thank you, JoAnn, for enlightening us, and hopefully we will have further discussion later.
Okay, thank you
Thanks,
all.
guys.
Take care.
Thanks, everybody.